It's my great pleasure and honor to speak at this important conference on behalf of Zurab and colleagues from Regional Committee of MT 2020 Plus and international experts from SWIN and Mission Thrombectomy. The name of my presentation is Mechanical Thrombectomy Access Core IMTAS in Georgia. And before I switch to the study which we did, just some facts about Georgia. Georgia is a small country in the South Caucasus region, bordering Russia from the north, Black Sea from the west, Turkey and Armenia from the south, and Azerbaijan from east, with an area of 69,700 square kilometers and population of 3.8 million inhabitants. 56% of population is living in urban settings. The capital is Tbilisi, located in the eastern part, with 1.2 million inhabitants, and GDP per capita was in 2019 was 4,249, which means that Georgia is in the upper middle income category by World Bank, and some social and cultural, maybe specific things. We have a unique language and alphabet, which is among 15th living alphabets right now throughout the world. And by UNESCO, Georgia is considered as a cradle of wine, with 8,000 years history of winemaking, and that's why it's a part of cultural UNESCO cultural heritage list. Some facts about stroke epidemiology. These are results of population-based study which we carried out in the beginning of 2000s. This you can see here that the age standardized stroke incidence, annual stroke incidence for 100,000 population, and you can notice that the figure is quite comparable of that for other European registries. But if you look at one mass stroke case fatality, this is a very high number. I think that after that we improved because of somehow improving the stroke services, but certainly it's a quite a sad number of figure of high case fatality in our country. So this is a map of distribution of mechanical thrombectomy capable, or in other words, comprehensive stroke centers in Georgia. Under this term, I mean centers which have highest volume of mechanical thrombectomies, and majority of these procedures are performed in these centers. We have 7 such a center in total, and majority of them, 5 of those, are located in capital Tbilisi. We have also 2 centers in the regions of Georgia, one in Kutaisi. This is a city with 125,000 inhabitants. Another at the Black Sea side region in Batumi, with population of 183,000 inhabitants. But probably most of you know this map of global MTXS. This is the data, this publication which was published 2 years ago in circulation. These results of the MT glass study. You can see here a very small red dot here in this region, which reflects Georgia. And in terms of estimated percentage of patients with a large vessel occlusion receiving mechanical thrombectomy, we are in the lowest range from 0 to 10. But if we look to another graph, which shows the MTXS by incomes, as it was already mentioned, there is a big discrepancy between high income and upper and lower income countries. But for Georgia, the number is slightly higher than 8%. Certainly, it's not that good as in higher income countries. But if we look at other upper middle income countries, we are not in the last row. Now let's go back to our study. The objective was to assess and characterize barriers to mechanical thrombectomy access in my country, in Georgia. And we did a survey of MT 2020 plus regional committee members, local members, 4-stroke neurologists, 4 interventional neurologists. All of us are practicing physicians from thrombectomy capable stroke centers in Tbilisi, Kutaisi, and Batumi. As a survey tool, we use recently elaborated mechanical thrombectomy access score. It was mentioned in Dr. Yavagal's presentation, MTAS, and this is a systematic and objective framework to measure or pinpoint the key barriers for mechanical thrombectomy access. And it's also known that consists of 12 attributes, 4 informational, 5 physical, 3 financial, as independent drivers of thrombectomy access, each scored from 0 to 3, with total score range from 0 to 36. And we use the nominal consensus method between us to finalize agreement for each MTAS attribute. These are results. We use the original chart in the original paper, which was recently published in Stroke. And you can see here primary barriers in different colors, information in yellow, physical in blue, and financial in pink. As to the public education programs in Stroke, it's possible to do only in the local urban centers. As to EMS utilization, we have much better picture with more than 67% of stroke patients brought by emergency medical service. As to pre-hospital LVO screening, again, we are not doing well, and the EMS transports the stroke patients in the nearest hospitals. Recently, this paradigm is tried to be changed by Ministry of Health, but we still this kind of situation. As to availability of transportation strategies, including intra-hospital transport, we have just an unofficial communication between EMS and stroke centers, as well as between stroke centers themselves. Emergency department stroke triage protocols are inconsistent and performed only at some selected emergency departments. As to vascular imaging, the situation is a bit better. It's consistently performed at both thrombectomy capable and primary stroke centers. As to stroke trained providers in emergency rooms, we have only few emergency rooms which are staffed with stroke experts. We do not have any stroke tele-network, unfortunately. As to availability of thrombectomy operators, we are doing quite sufficiently, 7 to 25% of operators. As to access to thrombectomy center, several centers are operating in most urban regions. As to availability of devices, we fortunately do not have only single option. We have several options, but these options are limited. And as to government reimbursement and health insurance, up to 66% of patients' costs are reimbursed either by government universal health care coverage system or private insurance. And this is a nice radar diagram which shows results of our study, with the best performance for EMS utilization and the worst for telestroke networks and pre-hospital LVO specific screening. And the total score was 17 out of 36. So you can see here that we have a huge room for improvement. And let me conclude. The MTS is a valid tool for quantitatively assessing barriers to mechanical thrombectomy in our country. And Georgia is a country with limited resources, so what I've mentioned before. They obtained MTAS identified the lack of pre-hospital LVO screening, insufficient MES and ED training, and geographical inaccessibility as major problems. We hope that the results of the study provide an objective framework to measure or pinpoint key obstacles to mechanical thrombectomy access in Georgia. And we also very much hope that we'll have the targeted public health intervention and the national strategic plan, including national stroke program, which will address these barriers. And this will definitely enhance MT workflow, streamline stroke care, and definitely expand access to mechanical thrombectomy in Georgia. And at last but not least, I'd like to thank all our collaborators, both in Georgia and internationally, and thank you for your attention.